really become an active member of the session. It's called an educational session, but I would like to do this like really interactive. The topic is low-grade glioma, which I personally think low-grade gliomas are maybe the most challenging brain tumors because it's not a black-white. There are many opportunities, and Eric Buffet, whom may some of you know who was the previous section head of neuro-oncology at the Hospital for Sick Children and one of the pioneers in low-grade gliomas, said always to treat low-grade gliomas is like art. And maybe I can convince you that it is a little bit like this. I'm Katrin Scheinemann, as you have seen there. I'm the chair of the SIOP-E brain tumor group. I'm also part of the low-grade glioma group, and I see that we have a good mix. So we have some junior people, but also some senior people, so hopefully we will have a nice discussion. These are my disclosures. And I would like to start off really with some cases. So case 1, 12-year-old girl, has some dizziness since 4 months, mainly standing up. Headache since 2 months, morning vomiting, walking issues. Most of you will already have some idea. I will show you the scan now. Something what you have expected. The tumor here in the posterior fossa, you most likely already have an idea what it could be. Next step clearly is you're going to ask the neurosurgeon to do a surgery. They did a gross total resection. You got the neuropathology. It's a juvenile pilocytic astrocytoma, BRAF fusion positive. And now, what are you doing? Is this patient cured? Or any hands up? Who thinks this patient needs further treatment? Who thinks this patient can just go now for observation only? Good. So now the tricky question is, when would you do the next scan? Who would do 3 months? Good. Who would do 6 months? No one. When you are asking your neurosurgeon, he would maybe say, let's do it in a year because I did it all. Good. What about this patient is stable, let me say, for 5 years? Then she is almost 18. What are you going to do? Because at some point you have to maybe transition her to an adult physician. Who would you transition her to? Do you think she would, an adult neuro-oncologist will take her? No, I see some. What about the adult neurosurgeon? So we just leave it as it is? I see, there is not a perfect solution, but you all know these are real cases, and you could say good biology, maybe nothing is going to happen. But you all know we like to keep our patients and see them for 5, 10, 15 years. And most likely, with a good biology case, gross totally resected, we're still doing potentially too many scans. But I don't think we have the right answer how often is good enough. And would you, in a case like this, to open up another discussion, use gadolinium or not? Could you do it with or without? Because there are questions which are coming now more and more from parents. They read all of these reports. Do we really need this? And in previous days, it was more an issue, really my child needs to have a poke and an IV access and get this. That is less of a problem, at least in my practice. They're more really looking, is this necessary? So that was an easy case. We'll now go from case to case to do it a little bit more tricky. Much younger child, 16 months old. Since birth, already a strabism of her left eye and a morning glory disc anomaly. And it went on and on and on. She was at the pediatrician, but it took quite some time until she got a scan. And you can see here the thickening of the optic nerve. And I showed you this, which looks normal, because maybe some of you have something already in their mind. So we tried to do some further things. They had visual potentials of the left eye. There are no potentials at all. Ophthalmology at this age, as you know, relatively tricky, but no fixation on the left eyes and no eye movements. What are you going to do with this child? Or what are you thinking of? Someone brave enough to speak up? Enrico.
Thank you, Patrick. Clearly, it's a patient.
Maybe that everyone can understand. Thank you.
So this looks like a patient with a high risk of having a long-term visual impairment. So you need to balance what you want to do to minimize this risk, and if you have an effective treatment which can do this. Because of the uncertainty regarding the efficacy of our treatment strategy for improving the functional outcome that is still relatively unclear, clearly you might consider a period of a phase of observation to see how the tumor behaves before launching the patient into a treatment. But it's not black and white. It depends on how you want to try to attempt to prevent any further risk of visual loss, or you wait to see if the tumor behaves in an aggressive way or not.
Thank you, Enrico. So who of you would treat this patient? Oh, look at this audience. What would be your factors to treat? I mean, the vision is already really bad, and I have to tell you, these are really challenging parents. They don't even want to come to the hospital. Which I didn't want to tell you in first place, because then what's clear, but this is relatively tricky. So maybe we cannot really do a lot for the left eye. The question is, will we have at some point an issue of the right eye if this tumor is growing more and more? And clearly that's why I showed you the other scan. At least at the moment, clinically, we have no signs for neurofibromatosis type 1. But that's tricky. Let's do one more case. 2-year-old girl, poor weight gain, but a good appetite and a horizontal nystagmus. And you all know what's coming, because there are always this like huge tumors. You all know what I'm going to, the encephalic syndrome. So what would you do for such a child? Thinking about, are you sending this child to surgery? Potentially, yes, but what are you going to tell the surgeon? You all have good surgeons, so maybe they all know what they need to do, but still the discussion up front is important. Or what should they not do in such a case? What surgeons like to do is take it completely out. Maybe not the best idea. And then you can really question like how much debulking is useful in such a case. Sure, if you cause not any damage, but if we're really gaining something out of that. But clearly, I think we need to know biologically what this tumor is. Does this child have a treatment indication? Yes? I see all. Yes, absolutely. And then let me give you a little, what treatment would you give such a child? And let's do it simple. Radiotherapy, chemo. Anyone would be given some of the newer targeted therapy? It depends. Good point. I also think that's something like really important. We have a lot of opportunities now, but we still need to gain more knowledge. And everything what we are doing outside of a clinical trial is a little bit like we're losing this knowledge in a way. It could be potentially beneficial for the individual patients, I agree, but we still have to learn a lot with all the treatment opportunities we have. So low-grade gliomas, you all know this, or many of you, it's the most common tumors in pediatrics. It's between 30 to 50%. Why is this so unclear? Like even the countries who have like really a childhood cancer registries, you know how this is. I mean, some are like incidentalomas, some are not biopsied, so that's why it's still a little bit gray. We can see this over all age groups. There is a median age between 6 and 9. And I think really important because you have low-grade gliomas in adults, but that's a completely different disease. And that's, as you all know, very important because all our parents today are going to Google it right away, and then comes all this bad stuff from the adults, but it's completely different in children. Predisposing factors, you all know that. It's phacomatosis. The most common one is neurofibromatosis. There you can see 50 to 30% developing then a low-grade glioma during the first 2 decades, so the one like where we are responsible for. It's mainly like optic pathway gliomas, but it can also be low-grade gliomas in other places. But please keep in mind, they can even get, during this time period, they can get a high-grade glioma. It's rare, but if there is some unusual features or so, don't think it's just because it's a neurofibromatosis type 1 that it's always a low-grade glioma. And then tuberous sclerosis, we will develop SIGA. That's also like something we commonly know. Symptoms, and that's now the tricky part. Low grade means, yeah, it's a low grade as due to the old WHO classification, so they are slowly growing. And that's why sometimes it's like the subtle symptoms, and you all know them. I mean, we are always then the ones who get the child at the end, mainly like already with a scan, and then we're always saying, yeah, but this child had like symptoms for months or years. But sometimes it's really not so easy. And you all know that the chronic hydrocephalus takes quite some time until like they're really making some syndromes. And sometimes it's like really, okay, the child gets maybe like if they're already in school, gets a little bit like worse at school and things like that, but you have to really pay attention for this. And even if you're thinking of an optic pathway glioma where it's so clear, but I mean, we all know this. I mean, there are tiny children, they're relatively small, and like at least I experience this often pediatrician, even if they have certain things, they send them to an ophthalmologist, and then it takes quite some circles before someone really thinks about this. Also endocrinopathies, even if we are measuring back and forth because we are pediatrician. Brainstem, that's maybe a little bit like obvious seizures and also. And what we have more and more the issue, I'm not sure how it is in your daily practice, incidentalomas. Because for more and more indications, it's not done a CT as in the old days, because everyone has now MRIs, and the MRIs are always getting better. And then it's like, oh, we get the phone call, oh, we just had the child in because it had A, B, C, D, and there is a tumor. What are we doing with all of these cases? Clearly no symptoms, and this can be big. I mean, they can sometimes be like 3, 4, 5 centimeters, and depending on the location, that's relatively, or I find it like really tricky. The parents are completely overwhelmed because like the MRI was done for a complete other reason, and then we found a huge tumor. How aggressive should we be? The answer in the adult world is quite clear. No one would just like watch and wait. They would all see we have to take it out immediately. We are a little bit more reluctant in this, and maybe then do a follow-up scan in 3 months or so. But 100% clear is it not. And if you're looking at the growing body of incidentalomas, yeah, once in a while you pick something out then, which seems to be a high grade or so, but I'm not sure if we would this have to change all of our approach. It's a really interesting question, and I think that's something maybe we will give a different answer 5 years from now. Where can you find low grades? Anywhere in the CNS. Clear posterior fossa is really common, but also the encephalic location, as you have seen, brainstem, cerebral hemisphere, and I think maybe what we're under-recognizing, if they're not highly symptomatic, are the spinal ones, and also the metastatic ones. Because so far, as you know, it's not necessarily mandatory to do a complete staging as in any other CNS tumor, so that you're doing a spinal MRI and doing a CSF. Maybe we would find more. The question is if it would really change our management, potentially. So I think the number of 5% maybe is not true, but we have no more evidence for this, at least right now. And then, as you all know, we had a new WHO classification in 2021. We lost some again, like pylomyxoid, astrocytoma are not longer in there. There's something new. There is still a lot if you look at this. It's all about grading and things like that. But the really more important biological factors are not so much recognized. And as you know, it's not only for low-grade glioma. This was an ongoing debate. Maybe it's a little bit more reflected in medulloblastoma. But I'm not sure that this honestly is helping us in the treatment decision or in any classification. And then our world, I think, was completely up and down when we figured out, oh, we can detect pathways in low-grade glioma. And it seems, compared to other diseases, that it is a single pathway disease. And that seems to be true now where we have more and more serious. You all know we started retrospectively analyzing this, but now are doing more and more prospectively, though it's just like one pathway. And you see there, I mean, there is mainly, as you all know, here the RAS-RAF pathway, so with the fusions and the mutations, but also NTRK can potentially play a role, even down here, and some other things. And obviously, it seems also to be something which we can find, technique permitted, in more or less everything. So the number of the ones where you can't find anything is relatively low, and this is shown in retrospective as well as prospective series, which opens up a whole new opportunity for targeted treatment. And there you can see, again, that's from the colleagues from SickKids. And just if you're looking on the right-hand side, so the blue ones are fusions, the red ones are the mutations, and only this purple one, which is 5%, is unknown. So obviously, also with not a lot of testing, you're picking up a lot. Here it's a little bit like more depicted. And it's already something, I mean, clearly I'm not sure how you are getting your first report from your neuropathologist, but no one would accept this if there's just like it's a pilocytic and you see nothing which writes her something of the BRAF fusion or mutation status. That's an information we want to know because like it really makes us helping decide how to treat potentially. Some are like really less. NTRK, as you know, and we have a lot of like medications for this, it's less than 1%. But there are like many alterations to find, changing completely how to treat. And then interestingly, as they're doing it, it's always like, can we do a combination of like really the molecular pattern and the location? And then you have this huge colorful things. It's nice. I mean, that's what we have seen clinically for quite some time. And you know this posterior fossa, in the old time you're taking them out, they're not coming back. So that's now matching quite clearly with like the BRAF fusion ones. But we always had also in the past the ones which we were thinking were gross totally resected and then are coming back after a few years. So there's maybe biologically a little bit more aggressive pattern. And as you can see here, I mean, the mutated one, that's more like really the hemispheres than other things. And you can do the same again. If you're looking now at the histological subtypes, which are still existing. So pilocytics are more like the fused one, ganglioglioma are the mutated one, and do it so on. It's a little bit similar as we have all this subgrouping, and you know this from medulloblastoma. Now the neuroradiologist already knows which subtypes in medullos it is. We are maybe not so far, but I sometimes have to laugh. I'm not sure how it is like with your neuroradiologist, if they're telling me already from the first scan it's that, and I'm like, yeah, now we don't even need a pathologist and a neurosurgeon to take it out. And now comes like really something which I think makes low-grade glioma so unique. It's pretty clear if you have a high-grade tumor, you have to treat it. I don't think that's necessarily so clear in low-grade glioma, and there are a lot of factors which you have to take into consideration. It's a clinical presentation, it's the tumor location, it's the operability. I mean, most of the neurosurgeons would say, sure, we can do something. The real good ones will say, not so sure. Biopsy for sure, and things like that has also changed our mind a lot. If you're thinking back maybe 10 or 15 years, Lots of time we said, like, we have done a few repetitive scans and said, yeah, it still looks like a low-grade glioma, and maybe we should not go for biopsy. Today, with our growing body and the biological factors, I think we are like really getting more like to biopsy and at least know what it is. It's then the combination of histology and the molecular profile, and also like the age, because clearly we have an issue. The younger the child is, especially if it's less than 1, they show a more aggressive behavior, and that influence the decision to treat. The European group, and it was mainly Astrid Kneko, who maybe a lot of you know, she's just like now going to retirement. They wrote a paper which is cited in our ESCP, what are clear treatment indications, or as clear as they can be, as you can see it here. And as you see, it's not like just one, so there are radiological criteria, clearly there are neurological criteria, then it's the infant population, which is like something you have to look on, and ophthalmology. And I think especially also ophthalmology, and Enrico here has done a lot of work on this. That's tricky, and you all know this, because the smaller the child, the harder it is to assess. And to find a good assessment, which we then can also translate, and that you can clearly see a vision gets worse, is really tricky, and you all know this. The 1, 2, 3-year-old child, yeah, you cannot just ask them, stand there, read what's going on there, and that's tricky. But that is also already like the age group which is really vulnerable. We have more and more technical opportunities to do this now, measuring potentials, OCTs, etc. But still, I think, at least personally, I'm not sure how you see this, Enrico, this is still a challenge, even with all the technical things we have. And it's so important if you think of eyesight. That's really something, we need this for our life, and a lot of depends on eyesight. So if you could have like age-independent assessment tools. And then I think what is also the thing, even if all like our scans and so are getting better, but there is always a lot of discussion. You see this number of tumor volume of 25%. How are you going to do this? There are programs now which can like do you volumetric measurements. But there are a lot of centers who don't have this. So you're doing this like old-fashioned and do like in 3 planes, you're measuring it and calculating it, and though, but you all know it's still tricky. Because what are you measuring? The T1 with contrast, just the T2. We have low-grade gliomas who have a solid part, but also a cystic part, and there is an ongoing debate what you should do so. So even if you think at 25%, which is a relatively clear number, it should be easy in day-to-day life, and you all know this, it's not so easy. And we have a lot of discussion in our tumor boards. Is this 25% or not? Should we do another scan? Because most of the time, it's not an explosion like this, but it's an evolution. And it's always, what are you comparing it to? The previous scan or the initial scan or the ones after surgery? And that's always like, we really have to look at it, that they are just not comparing it to the previous scan. Because then at the end, you can have 75%, but you have not looked at the right scan. That's still an ongoing debate. New lesions, new metastatic lesions, that's maybe a relative clearer. Neurologically, clearly, and that we have seen, and that's also nicely shown by Astrid Kneko, diencephalic syndrome is a clearly treatment indication. There is no ways to get these children, which are severely sick, and I mean, we still have children who are dying of this, they need like really treatment. And to give such a child chemotherapy can be also like really, really challenging. Infants, clearly, they have a more aggressive behavior. And CGAS, I mean, that's relatively clear if they are blocking something. That's a short list, and it's not complete, but it gives a little bit of a framework, because that's also a thing we have to look up in our trials. Because if any one of us is using their own criteria or their local criteria or national criteria, it's really hard at the end to compare. But as I said, in low grade, it's not this black and white. So like, what is a clear treatment indication can be relatively tricky and needs like a lot of discussion. And then what are the treatment options? Surgery is quite clear. We have chemotherapy since the 70s. The radiotherapy, that's still something we can discuss. Targeted therapy, and I mean, what we're not doing so rarely is watch and wait. Does it grow? Doesn't it grow? And you all know low-grade gliomas can even sometimes regress spontaneously. That's overall a relatively weird tumor. They can do everything and nothing. Makes it also tricky, and I'm not sure. And that's also like something which I think for a lot of parents is hard to understand. And I can get this. My child has a brain tumor and you're doing nothing about this. You're not taking it out. You're just doing follow-up scans. Yeah, and it's safe to do so because potentially you are doing more harm if you do something. Let's start with radiotherapy. That was at the beginning the only treatment option because we were not sure that chemotherapy is working. And then it was like, yeah, it's good. And now we're saying, oh, it's completely bad. And maybe the truth is somewhere really in the middle. There was a lot of papers out on this, so should it be even considered at first line? And first we were saying no, but I think now we have a little bit more of a discussion going on that for certain cases, especially in older kids, it could be a relatively good treatment option. And there are some study groups who always had also a lot of experience with brachytherapy, which is also working very well. So I think from going, yes, it was, to no, we're not, this is not a treatment option at all for low-grade gliomas, we're bringing it back into the debate. But it's not completely done yet. Chemotherapy. Since the 70s, so carboplatin and vincristine was most likely the most used ones. There are some slight differences between the European and the US schedule. Then the Canadians brought up the vinblastine monotherapy, so that's just vinblastine once a week. Then also from the Americans, as the other randomized arm was this TPCV. Then there are some combinations with bevacizumab, either with irinotecan or now the ongoing vinblastine, though there's a lot of combinations. And at the end, all of you have a lot of experience with this, it's more how well is it tolerated and how long can we stabilize this? Because we know most likely if you do one round of chemotherapy, in a lot of cases you have to do another one. And if you're thinking of vincristine carbo, and we all have seen this, it's allergy to carboplatin, depending which series you are reading, it's sometimes up to 30%. There is a certain nephrotoxicity with this. Vinblastine mono normally is relatively well tolerated, at least in the smaller kids. My experience is the older they are getting, the teenager then you see really they're dropping their counts and so, though they have more toxicity than the smaller ones. TPCV as a combination for sure is a little bit more toxic. Vinblastine, Avastin seems to be working really well, even if you're thinking the concept, but it's such a tumor, should I really use Avastin? Because that was more for this highly aggressive tumor, but it seems to work. Though there is still, and there are some other combinations out there, so I don't think it's really the right answer. What would be really nice to have something oral? Don't you think for a disease like this, this would be really nice? And then the whole world opened up for targeted therapy. So we have MEK inhibitors, we have pan-RAF inhibitors, we have BRAF kinase inhibitors, then mTOR inhibitors, clearly for SIGAs, and NTRK inhibitors. There we have already some evidence. There have been certain phase 2 trials. We are now opening up also phase 2-3 trials. So that's nothing we can say. We know they can respond relatively well, but there is also some issues with that. What doesn't seem to be a bigger problem is crossing the blood-brain barrier. What is sometimes a little bit of a problem, and you may have also seen this, are some side effects or acute toxicity, just if you're thinking, for example, for skin toxicity. So it's really important that you have dermatology in. And then there comes this huge discussion of treatment duration. In chemotherapy, we're saying, yeah, we're giving it for 12 to 80 to 24 months, and then at some point you stop, even if there have been patients obviously who have been on this for years. If you're thinking of a targeted treatment and you're stopping it, it's clear what's going to happen. You have a rebound. So how are we going to deal with this? Should we never stop? That's a tricky question. Don't you think, are we feeling comfortable to give a treatment 5, 10, 15 years? Will we experience then resistance at some point? If not, when are we doing for the so-called drug holiday and then restarting? Or should we find a dose which is maybe the lowest dose where you can see a response? And I think these are really interesting questions on ongoing trials. And what we don't know, and I think that's something we have to keep in mind, and that's with all the newer medications, what are the long-term side effects? You all know we know them very well for our common chemotherapy, but we don't know them for the newer things. And we have to keep this in mind, because these are children who are becoming adults and hopefully will have a full life. And why do we have to keep this in mind? If you're thinking of the overall prognosis of low-grade gliomas. For the ones you can take out and are like a gross total resection and it's not come back, so that then maybe you are cured. But even these children, and we learned this really the hard way, think of the first ones who had posterior fossa, low-grade glioma, it was taken out, we let them go, and then years later they came because there were some neurocognitive issues and they had issues in school. What was the issue? The chronic hydrocephalus, which we really underestimated what could it cause. So at the end, I think we have to look at low-grade glioma if you still have some residual tumors as a chronic disease. And with all chronic diseases, your treatment has to help, but your treatment cannot be more toxic than the disease itself. And that's sometimes not such an easy balance. If we're looking poorly at event-free survival with chemotherapy, okay, that does not look good. We all agree on that. It's not like in other tumors where we have way numbers over 80. Really looking over all trials with everything, it's less than 50. But we have a few patients who are doing way better. For sure, it's the neurofibromatosis type 1 patients, but maybe some others. And this one also, they need other rounds of chemotherapy. And think about this, even if you're using the same substance group, like vincristine and vinblastine, it's working again, which is completely weird. But there we have also sometimes conflicting evidence, because the Canadian group has shown you can use the same one from the German group, it didn't look as great. So there are a lot of open questions, I would say, but which are really important. And we also have to keep in mind, which is thankfully, at least to our knowledge so far, not such a problem, is the malignant transformation, which you've seen in the adult. You all know this. I mean, in adults, it starts normally as a grade 2. It's the first progression, you are a grade 3, and then you're ending up in a grade 4. We don't see this, at least not through the pediatric period. But does this change once they are 18, 20, 25? Because the adults, if you have then to transition them to the adults, and I've often done discussion with the adult neuro-oncologists, they're you cannot let this go like this. We have to take it out because we don't know what happened. If we are assuming the biology will stay the same, at least if we're seeing this through pediatrics, and this will also stay to adulthood, we have to convince them that they can use our approach and don't have to be too aggressive. So I think we have a lot of questions to answer, but it's also a really interesting time we are in with all the opportunities. And it's great at the end that we have so many treatment opportunities. But I also think maybe also not for every child targeted therapy is the right answer. So I would not say now, because we have all of this, chemo is not out of the question. Maybe there are some kids which will benefit from chemotherapy. Maybe we can use vinblastine because that's just one drug and well tolerated. But it also makes it really tricky, because we have to identify risk factors in the individual patient. Why would he better be for targeted or something else? And that's a challenge, but interesting. And if we are doing the same talk in 5 years, it would be really interesting to see what are we going to tell then. What trials do we just have open in Europe? We have open Logic Core, which is just like a molecular diagnostic registry, and I will show you just the first few results. Just opened in a few centers already is the Logic Firefly 2 trial, which is randomized for non-neurofibromatosis patient. It's chemotherapy versus tovorafenib, a trial we have prepared for a very, very long time, and I think which is a very important trial where we exactly want to answer this. The French group have the so-called METRIC trial open, which is also a randomized trial, which is comparing trametinib through vinblastine over 18 months. And then, at least not open in Europe yet, but open in the US, is ACNS 1831. We are trying to do this transatlantic, but I can tell you it has been a huge challenge so far for patients with neurofibromatosis type 1, where it's also chemotherapy versus selumetinib. And I think it's so important that we're doing this randomized trial, because we need to have these answers in a randomized fashion and really greatly analyzed. And all of these trials are really open wildly. I mean, for Logic Firefly 2, it's 100 centers across the world, and I think that's really important, and we have to really see that all of these trials are recruiting relatively fast. We need this answer. Because these are patients, we have a lot of patients like them, and as sooner as we have results from this trial, that will also help them to really see what treatment they need, what we can offer from them, and that then all these medications are also licensed. And these are the first results from Logic Core. So for those who are not familiar, that's really so. So each country has a so-called national hub. And there they're doing the first level of molecular analysis. So that's the usual one. It's the BRAF, BIEH. And then in a second analysis, all goes centrally to Heidelberg. And this is just like the first analysis. And as you can see here, you have hardly any low-grade glioma where you could not find a target. And it still seems the same, it's a single pathway disease. So that's now like in real life, real time, also to set this up. There were some, as you can see, some logistic issues at the end. But this is also a trial recruiting a little bit like across the world, took quite some setups. And it's nice that like all the national hubs really had to be certified like from the international sponsor. So there is also huge quality in doing all of that, which I think is so important, because if we're depending all of our treatment decision at the end on such an integrative diagnosis, it has to hold up over all of this. Let me quickly finish with the brain tumor group for those of you who are not familiar with. The SIOP brain tumor group exists for over 50 years now, already with the goal initially to run like not only European but international trials. And we really try whenever this is possible to do a transatlantic cooperation. With all the issues we have, I'm quite honest with this is a major challenge to do so. The structure is that we have like tumor working groups, as you can see here. So it's low-grade, high-grade ependymoma, embryonal tumors, germ cells, ATRT, craniopharyngioma, and choroid plexus. Within the embryonal tumor groups, we have now a subgroup which is taking care of all this like rare new embryonal groups, the former PNET group, which does not longer exist. But we also have all the disciplines in which are so important for pediatric neuro-oncology, as you know. We need the neurosurgeons to be there. We need the radiotherapists to be there, biology, but also thinking imaging and quality of survival, as you all know. Unfortunately, survivors of a pediatric brain tumor, as you all know, have still the highest morbidity and mortality. So with each new trial, we are like really designing, this has to also come into consideration from the beginning. What I would also like to ask all the young people here who now thinks, yes, my heart is in neuro-oncology, do it, it's great, come to us. There's a young investigators group and there is a training and education group. And there are a lot of people there who really like to mentor you and to get you into this. It's a big population, it's a challenging population, but it's also like really interesting and challenging. And you have to like to work in a multidisciplinary team, because that it is what neuro-oncology is. Just to advertise a little bit our next meeting, so we'll meet in Berlin in September. So the first 3 days is our combined neuro-oncology course for 5 years now. We have a 3 years curriculum for young investigators to really get a complete roundup over 9 days about everything. We cover really everything for pediatric neuro-oncology, all the aspects. It's really interactive. All the experts are there. Sorry, you have to write a test at the end of each day, but that's just to show a little bit like that we are doing well. Be there, and then we have our annual meeting. And next year, as usual, we will meet with the ISPNO in Philadelphia. So please mark your calendar already. Another initiative to show you, I'm not sure how many of you have seen this, via ER and PET-CAN, we have developed this European standard practice guidelines, especially for countries where there is no clinical trial open. The brain tumor group had a lot to develop, as you can see here. We are almost done, so it's only choroid plexus tumor, which we are still missing, in pineoblastoma. And we're just also in the process to work them all up as manuscript. The issue is the ESCP, you can only get access to them if you're a SIOP-E member, because they're hidden on the SIOP-E website, so we want to make them publicly available. Also know with this we have now a huge responsibility, because as you have seen, science is changing fast, so at least every 3 to 5 years we have to update them. But I think it's, for us, it has been a great work to do it together as a group, but I think it's also a good reference. And with this, we have time for more discussion, and I thank you very much for your attention. Are there any questions or comments? Enrico, please.
Thank you, Catherine, for this excellent overview. Well, I thought it was interesting to present also what you should not do with these patients, or what is important that you don't do. So don't treat the tumor only, so always consider the child and its clinical condition. Then regarding targeted treatment, not all the targeted treatment work for each of the genetic alteration. Particularly, it's worth mentioning that for BRAF mutation, BRAF V600E mutation, for BRAF fuse patient, you shouldn't absolutely use a BRAF V600E inhibitor like dabrafenib or vemurafenib, because they have shown previously that if you targeted with this kind of level of the pathway, you cause paradoxical activation of the pathway. So if you have a BRAF fuse patient, you should use the downstream inhibitor, or maybe the pan-RAF inhibitor, which might work as well. But don't use the sorafenib, first generation inhibitor, or dabrafenib, or vemurafenib. Don't forget to assess function, also both at diagnosis and at the long term, because this patient will end up having a chronic morbidity, so you need to assess them and to implement rehabilitation practice and services since the beginning. And last but not least, don't rush in decision to treat patient, but always take the time to see how things are and how the patient behaves in some times. These are kind of a...
No, perfect. Thanks for summarizing this again, Enrico. And assessment tools, if you need any, we have tons of them. We are really looking into this also in hierarchical assessment, though that's really important. And drugs, especially for the BRAF V600E mutated one, are now broadly approved already, like within Europe, or get approval by the end of the year. So that's something which is available. But I think thank you for summarizing the important point, and think of it as a chronic disease and the long-term follow-up in any decision you make for this patient. Any other comments? If not, thank you and enjoy the last hours of the SIOP meeting.